So what we talked about on Friday, we started into patient factors. So we finished up with radiographic technique and got into patient factors. Talked quite a bit about that. We might finish up today. Finish up the chapter. So what do y'all have a test on Wednesday by chance? Next week? No. What I propose we do is try to push through and finish up chapter today. I'm working on the review sheet. I need to kind of change some things on the review sheet. I'll get it finished up and get it posted. And maybe spend Friday going through the review sheet, making sure that we touched on everything, and then have test on Wednesday. Sound good?
Sounds great.
Okay. All right. So then, real quickly, we'll go through the patient factors. We'll review that. We talked about patient factors in context of body habitus. Really, body habitus and part thickness kind of went hand in hand. And we said that for the most part, whenever we have changes in body habitus, the accepted norm right now is to change a specific technical factor, and that was which one? Mass, exactly. So that's regardless of whether it's fat, muscle, air that we're looking at. We, for the most part, are going to, and most of the time bone, but for the most part, we're going to adjust our mass. But there were times that we would adjust our KVP, and that's whenever we had an effective atomic number increase that was substantial enough that it could interfere with absorption characteristics of X-ray, being able to absorb more X-rays than what we wanted it to, and then we might change our KVP. So most of the time it's going to be mass, and that's going to be by change of a range. How much? Remember? 30 to 50%. Right? So if we have an additive condition, we would increase our mass by 30 to 50%. If we needed to make a change in KVP, that was 5 to 8%, right? So that applied to pathology as well. We have two different types of pathologies, essentially, that we have to consider in technique selection. That would be anything that adds either radiolucency, which would reduce radiopacity, or anything that increases radiopacity. It increases the effective atomic number. Now, we generally refer to effective atomic number of tissue types because, you look on the elemental table and where do you find muscle? It's not there, right? So the effective atomic number of a tissue type would be, kind of the average of all tissue types, considering their abundance in that tissue type. So we talked about some basic definitions. We've got density, and we have patient density. We have radiographic density and patient density. That's basically how absorptive the tissue type is. And then we had radiographic density, and that's how dark the image is. So we have an inverse relationship. As patient density goes up, radiographic density goes down. As patient density goes down, radiographic density goes up. Right? So we talk about patient factors, thickness with body habitus. We talk about hypertrophy, which is overdevelopment. Hypotrophy is underdevelopment. And technical factor of choice then was mass in most cases. Composition, again, the only time that we would increase KVP is if we have an overabundance of bone, or if we're putting something inside of the patient that we needed to increase our KVP to penetrate, like barium, something like that, right? So most of the time it's going to be mass, but sometimes there are rare cases where we need to adjust our KVP. And pathology, again, we're going to talk a little bit more about pathology and specific pathologies in a minute. And rules of thumb we already talked about. So we have additive conditions, which are constructive. It's not constructive in that they're better for the patient, but they're just additive, right? So additive conditions add patient density, and they're constructive in the tissues. So it increases radiopacity. It might require increase in KVP, but most of the time we can get by with mass. All right, so the reason that we want to reserve KVP for the most part for increase in bony density is because what we get in soft tissue, any kind of soft tissue, is as we add soft tissue, then we increase the likelihood that a photon will undergo a scatter interaction. So scatter degrades the image, lays down a layer of fog. It can degrade the image. And with our modern image manipulation, it might not have as drastic an effect as what it had in screens and films, but it still lays down that layer of fog and can potentially degrade the image. So as a result, the accepted technique correction is not to increase KVP because you compound the issue. As KVP goes up, you remember we talked about all interactions go down, but photoelectrics go down faster than anything else. So what we have then is a greater percentage of scatter radiation. Now, if we increase our KVP and penetrate things that create more scatter radiation, it compounds the problem, right? So bone, we don't have that much of an issue with, and the issue really in bone is we're still going to create scatter radiation, but a lot of that scatter radiation is not going to penetrate through the bone, right? So we get a lot of photoelectric in bone, and as a result, if we have an overdevelopment of bone, then we might want to increase KVP. Otherwise, universally, it's going to be that 30 to 50% change in mass. So things that increase atomic number, we have pleural effusion. What is pleural effusion? It's in the pleura. Is it too much air or is it water? It's water. It's fluid, right? So again, we go back to what we know about KVP and fluid. Since it's fluid, we don't want to increase KVP. We want to increase mass, right? So we're going to skip over CAS. We're going to go to aneurysm. Really, for the most part, you're not going to have to do much with an aneurysm. An aneurysm is going to be an addition of fluid, but it's going to be fairly subtle, and it's going to be an addition of fluid in an area where you have a lot of fluid. So where we see an aneurysm that you might recognize will be in the abdominal aorta. And what an aneurysm is a blood vessel that the wall weakens and it just stretches, right? So you've got this increase in blood in the abdominal cavity. So really it's not going to affect a whole lot, and you wouldn't know that it was there, right, until you made your x-ray. So technique adjustments, not really so much. Ascites, we talked about. It's important to get an idea of what's going on with the patient when you walk in. And the patient looks kind of bloated, right? Remember talking about that? If the patient looks kind of bloated, it's important to determine if this patient's normal anatomy, or if it's the patient's, if they've got a bowel obstruction causing that bloat, or if they've got ascites. So if it's a bowel obstruction, then what did we say that you needed to do? Because if you got a bowel obstruction, what are you full of? Air, right? So what do you need to do with your technique? You got air. Air is hard to penetrate, right? No, it's not. So you would decrease your technique by 30 to 50%. With ascites, you would go the opposite direction. Pneumonia, it depends really on how severe the pneumonia is. You might need to increase your technique again 30 to 50%. Some cancers, especially bone cancers, are going to be subtractive, but some cancers may cause things like bowel obstruction. So if you have a colon cancer, it could cause a mechanical obstruction, and then you've got basically a subtractive, destructive process, so that you've got more air. So you got to know what kind of cancer we're looking at. Atelectasis. What is atelectasis? Collapse of the lung, right? So as collapse of the lung, we tend to associate that with a different condition that we call the most common condition that causes the collapse of the lung is pneumothorax, right? But collapse of the lung is kind of like a broken rib, all right? So you got a broken rib, but what's going on with the broken rib, right? So is it that the patient has a pleural effusion that's leading to the atelectasis, or is it a pneumothorax that's leading to the atelectasis? So if it's pleural effusion, leading to the atelectasis. So that just means collapse of lung, right? So if it's PE that causes atelectasis, what do? Yeah, you increase 30 to 50%, but if it is a pneumothorax, then you might go in the opposite direction with it. And osteoarthritis, remember we have a couple of different types of arthritis. We have osteoarthritis, we have rheumatoid arthritis. And has anybody had a patient with rheumatoid arthritis seen the bones? Mm-hmm. Looks a lot like osteoporosis. So the bone gets eaten away greatly. Lose bone density. With the osteoarthritis, what you'll have is an increase in density at the articular surfaces. Overall bone density doesn't necessarily increase, but at the articular surfaces, the bones get brighter. Okay, so you really don't need much of an adjustment for osteoarthritis, if any at all. You probably, if you know you've got a patient with rheumatoid arthritis, then you're going to need to decrease and possibly KVP in that case. So rheumatoid arthritis, in a lot of cases you can see without making the x-ray that the patient probably has rheumatoid arthritis. They'll have deformities of the fingers and stuff like that because those articular surfaces are just completely eaten away. So pathology is a decrease. Radiopacity would be what we call destructive, and they decrease the effective atomic number. That would be atrophy. Again, it sometimes, I sometimes have a hard time separating the different portions of a lecture I might cover with sophomores versus freshmen. Did we talk about the amputee and the lateral chest x-ray in here? No? Okay, so you've got an osteoporosis. You've got a couple of different things going on there. You have pathological osteoporosis, and that is where you have somebody who's probably postmenopausal and they're undergoing osteoporosis. Reabsorption of the bone that you destroy, essentially, doesn't get put back into the bones, and you get a loss of bone mineralization. But you also have what we call disuse osteoporosis. So what you have there is if the patient has a shoulder that's locked, right, and they can't move it very well, then you may find yourself in a situation where you have to do a lateral chest x-ray on a patient who can't get their arms up, right? So I've had a patient that was so bad, she was an amputee, and most of the time when you have a patient who's an amputee, they don't amputate at the joint, because what they want to do is they want to give enough tissue on the stump to, they want thick tissue on the stump, right, for padding. And the tissue at your elbow, let's say, isn't very thick on either side. It's pretty thin, so they tend to go above or below. And if at all possible, they'll go below. Now, the reason for that is because even if a patient has an arm that's let's say they've got some neuro damage and they can't move that arm at all, but it's still flexible enough and it got range of motion, they can move it. With the other hand, they'll leave as much of the arm as possible because it does have a function. If you tear out a piece of paper and you try to write with one hand on top of the desk without anything on that piece of paper, what happens to the piece of paper? It tends to move all over the place. So in a lot of cases, they'll leave as much as possible because there still is a little bit of function to it. You can still use it for certain things. It's a paperweight, basically. Well, this paper, it sounds cruel, it does, but it's the fact of the matter. And this patient, they went above elbow. Okay, so for whatever reason, they had to go above the elbow. And so it had no function. It just hung there, and we did a lateral chest x-ray on her, and she couldn't move her arm more than about like this because, it's pretty much locked in place. Shoot a lateral chest x-ray right through that humerus, you almost couldn't see it because it had disuse osteoporosis. So, destructive, and we thought it cast a big artifact, but it didn't. So we have disuse osteoporosis because of the atrophy of the muscular tissue and also the bone as well. So emphysema, what is emphysema? We see a patient, it's a lung issue, we see a patient dragging around an oxygen bottle, and most of the time that's some sort of COPD, and a lot of times that's emphysema. So you see a patient with emphysema and you listen to them, and what do you hear? In a lot of cases. A little wheezing, right? So we have a tendency to associate that wheezing with the patient having a hard time getting a breath, but that's not really how it works. With emphysema, what you get is a loss of elasticity of the alveolar sacs. So the alveolar sacs, think of it kind of like the elastic on your socks, right? The elastic on your socks is there so that you pull your socks up and it holds onto your calf, right? But if the elastic on your socks gets old, then what happens? Socks fall down. They lose that elasticity and they don't squeeze back in, right? So now apply that to your alveolar sacs. If you have alveolar sacs, healthy alveolar sacs, it's like elastic. So you breathe in and it stretches them, but when you relax, then they go back to a smaller state and it expels the oxygen, or used oxygen, CO2, the air that's in there. So if they lose that elasticity, then what you get is constantly open alveolar sacs. So what you're hearing is not necessarily the patient having a hard time getting a breath in, they're having a hard time getting a breath out. So it's forced exhalation is what you're hearing. So now apply that to the overall lung. If those individual alveolar sacs are staying open much more than what they should, then what you have is too much air inside the lung. Where you have a pneumothorax, you got air outside of the lung, but in the thoracic cavity in places it shouldn't be. With emphysema, what you have is too much air inside of the lungs. So what that does is it takes all those lung markings, it spreads them out more, and what you get then is a decrease in tissue density. So you need to decrease your technique. Pneumothorax, we already talked about. Rheumatoid arthritis, we already talked about. Both destructive. So how do you know what you're dealing with? Telltale signs, we talked about some of those last week. You know, you walk into a patient's room and they've got a NG tube in and it's hooked up to suction. That's a pretty good indication the patient has, and they have a distended abdomen. That's a pretty good indication the patient has a bowel obstruction, right? So observation is one, but also, you know, check the chart, ask the nurse, anybody who's around. You walk into a room and there's a bedside table, and that bedside table has a sterile tray on it, and that tray has guide wires in it, and the guide wires have blood on it with a needle. Okay, does that sound like any kind of kit that they would be putting an NG tube into the patient? You gonna put an NG tube into the patient with a needle? Mm-hmm. No. Should you have a lot of blood if you put an NG tube on the patient? I hope not. So probably then what you might want to do is maybe uncover the patient's shoulders a little bit and look for what looks like a fresh central line. All right, so when you're looking for central line placement, you're really looking for two things, and the most obvious is the least important. All right, so you get called up to the patient's room and they say, okay, we just dropped a central line into the patient. You think you're going into the room to see where the central line placement is, right? And you are. What they want it to be going into is superior vena cava, possibly all the way down into the right atrium. But if in placing the central line, they had a hard stick and they were digging around inside there quite a bit and they went subclavian, then it's rare, but the possibility exists that they could have hit the lung. Not necessarily the lung, but the pleura, right? So what's more important to see? Whether or not the lung is inflated or if they need to advance the central line another half an inch. That position of central line is secondary to whether or not that lung's any good. So your technique should reflect that, right? So if you, and it's really, I hate to keep saying this over and over again, but your computer algorithm is going to enable you to see both of those things. But if you find yourself in a situation where you're having to select between two techniques on a test, one for central line placement and one for pneumothorax, your default answer there is going to be you're more interested in seeing the lung. Make sure the lung's inflated, make sure that you don't have pneumothorax. So in clinical practice, it's really not all that much of an issue. If you have a good technique, you're going to be able to see both of them. So look for telltale indicators. That should be NG tube, central line, chest tube placement, that sort of thing. So central line is always more, pneumothorax is always more important to visualize than central line placement. So in some rare cases, I've shot a portable chest on a patient one time, and it was a terrible stick. I mean, they dug around this patient forever, it seemed like. And the central line was actually going up into the jugular, rather into the superior vena cava. And just to illustrate and drive this point home, the doctor decided not to try to change the position of the line. Is that going to be a problem? Well, think of flow of blood. It's not ideal, and it's kind of ugly and probably embarrassing for the doctor that he couldn't get it, to go in the right direction. But think of the flow of blood. Which way is blood flowing in the jugular? Is it going up into the brain, or is it coming out of the brain? It's coming out. It's coming out, right? The carotids go up. The jugulars come down. So if they push medicine into the jugular, it's just going to wash straight back down where it's supposed to be anyway. It's not going directly into the brain. So, and I only saw that once in my entire career, but that is a possibility that you may see. All right, so image quality factors, image receptor exposure, everything. All the image quality factors affect image receptor exposure, right? KVP, direct, exponential, mass, direct, be that MA or time, and then our SID, changes in SID, we have an inverse relationship as an inverse exponential relationship. So as we increase our distance, we decrease our image receptor exposure. So what things affect sharpness or recorded detail, potentially, in our technical factors? Well, KVP has none. KVP doesn't affect our actual sharpness or recorded detail. There might be some effect on visibility functions because of fog. So fog, remember, lays down scatter lays down a layer of fog. That might interfere with visibility, but sharpness or recorded detail has none. But can you see any way that we've talked about that MA, time, or mass could affect actual sharpness or recorded detail? Why do we use reciprocity? Increase MA, decrease time, right? Why would we want to do that? Motion. Motion is the number one thing that is mostly out of your control that will destroy sharpness or recorded detail. You can't completely overcome, what the patient's going to do, right? But you can use reciprocity, increase MA, decrease time to affect a shorter exposure time and reduce the probability of motion artifacts. So motion is one, and we've talked about another one. It's a little harder to wrap your mind around, but how about what happens whenever we have extended prep times? What do we get? What's that? Blooming, exactly. We get overexpansion of the space charge, so that when we send the electrons across the tube, they're going to interact on a larger portion of the target. If they interact on a larger portion of the target, it increases the focal spot size. If it increases focal spot size, it decreases sharpness or recorded detail, right? So we don't necessarily have to have extended prep times to get to that either, to get to a loss of sharpness or recorded detail. If we have a very high MA station, we select a very high MA station, same thing can happen. And that's part of the reason that your X-ray tubes are exposure limited for small focal spot size, is because you want to maintain that sharpness of recorded detail. So it doesn't do you a whole lot of good to have a small focal spot size if you're going to bloom, your space charge quite a bit, right? So distortion, remember we've got two different types of distortion. We've got size distortion, we've got shape distortion. Size distortion, remember, is equal magnification. It's still distortion, it's just equal magnification all the way across the image. So all anatomy distorts size-wise equally. So how do we overcome that? Size distortion. What do we do if we can't get, what controls our size distortion, our magnification? OID primarily, right? So we want to reduce our OID as much as possible, but if we have an increase in OID, what do we do to offset the effects of that size distortion? Increase SID, right? And if we have a doubling of our OID, let's say we're at 4 inches here, and I go back to 8 inches, as long as I double my SID exactly by the same ratio, if I'm at 40 and I go back to 80 inches, then it completely nullifies magnification. Okay, what other type of distortion do we have? We have size distortion, but what else do we have? Shape, right? So what affects our shape distortion? What's that? Positioning issues, yeah. So it's positioning something. It's either going to be positioning of the central ray, positioning of the part, right? So, you see my hand here, my fingers look, normal there, not so much here, right? So we got to have the fingers look shorter than what they were. That's for shortening. Can't really demonstrate that up here, elongation, but with elongation, usually what you have with elongation is angulation of central ray, angulation of the image receptor, something like that. So those really have no effect or no part in what we're talking about here with technique, but it bears mentioning. And then, artifacts get in the way of everything. Any kind of artifact, remember we've got internal artifacts, we have external artifacts. If a patient has a pacemaker, they got a pacemaker, right? It's going to be an internal artifact. But if the patient has EKG leads, we can get rid of some of those EKG leads. Best way to do that is just pull them taut and pull it, straight down. If you're doing portable, just put it between the patient's legs. If you're doing upright chest X-ray, and then just take it out of the harness and put it, or the holder, and let it hang, right? And you can get rid of some of those EKG leads. So get rid of what you can, and don't worry too much about the rest of it. So we talked about optical density. That's the darkening, the blackening. It's an indication of exposure, and it's controlled primarily by the lookup table. Certainly you have to have exposure in order for it to calculate that. But here's the thing. The overall image is going to be created by whatever the computer sees. All right, so let's say we shot my hand on a 14 by 17 image receptor and it can collimate. What the computer is going to see is back up a little bit. With computers, you get, if you feed it garbage, you get garbage out, right? So they say that garbage in equals garbage out. So if I were to shoot my hand on a 14 by 17 image receptor, 17 by 17 image receptor, not collimate, what the computer's going to see is it's going to see my hand, but it's going to see all these dark areas, this enormous dark area. And it's going to think that I overexpose that patient greatly. So even if you use a perfect technique, because of all that dark area, that increase in density, what I'm going to have is a misrepresentation of the contrast, right? So I've got all that density, and what's going to happen is it's going to try to make sense of what you did. It's going to think you overexposed all those individual image receptors, and you're going to lose contrast. So in that way, the computer algorithm controls your contrast and density, And sometimes it doesn't do you any favors in that. You have to give it good information or it's going to give you back bad information, right? You give it garbage, it's going to give you back garbage. So it controls the lookup table. The lookup table is the stored computer algorithm, right? So it's the algorithm that is inside of the computer that is going to compare your algorithm, your histogram to, okay? So think of it like this. You make an exposure, and if you get into the histograms, they're just these little numbers or these little lines that go up and down like that. Okay, let's say the preferred algorithm looks like this, and you shoot something that looks like this, right? So what you get inside of the computer is you feed it this, and it wants it to look like that. So what it's going to do is going to go through a process called automatic rescaling. And the automatic rescaling is applying your histogram to the saved lookup table. And it's going to take your range of exposures and it's going to make it look like what's in the computer as much as it can. Okay, so it's applying the process of automatic rescaling is applying your computer algorithm to the lookup table to kind of narrow those range of exposures to make it look right. But if you feed it something it can't make any sense of, you're going to get errors, right? You're going to get an image that doesn't look like what it should look like, misprocessed. Okay, so it's going to largely be controlled by the lookup table, but that is providing you give it good information. If you don't collimate, it's going to mess up your image. If you use way too much of master KVP, it might mess up your image. Right? So you got to give good information. Okay, so again, exposure control. You got your MASH, you got your KVP, overexposure, underexposure. You might lose some contrast with either one of those. Your image receptors can differentiate between high voltage or high KVP X-ray photons and low KVP X-ray photons, but once it feeds it into the computer really just sees it as exposure. And if you overexposed or underexposed by a little bit, it'll correct that. Right? That's a benefit of digital processing. It'll correct that. And in that, we have exposure latitude, right? So minor changes in your technique, minor errors in your technique manifest themselves as a difference in index number, right? Could be S number, EI number, whatever it is that your institution uses. Those numbers are pretty indicative of how much you over or underexpose a patient. Okay, so what I mean by that is some of your index numbers, if you overexpose a patient, the number goes down. Okay, so let's say your perfect number is 200. If you overexpose the patient by a factor of 2, there's a direct relationship in most of those cases between your exposure and that index number. So if there's a direct relationship and you overexpose the patient by 2 and your perfect index number is 200, then what that means is your index number is going to give you, your index number is probably going to be 100. Does that kind of make sense? So would you go back in and repeat that? If the image looks good, that's not a calculation on the test. So, I see you looking around and that's not a calculation on the test, so it's just an example. All right, so would you go back in and repeat that if your image gave you the information that you needed to see? No, you wouldn't. Why? It'd be unnecessary, right? And not only would it be unnecessary, but you overexpose the patient by a factor of 2, you're going to go correct your technique and go repeat it. Now you've given the patient triple dose. Right? But would you use that same technique the following day if you had to do it again? And the answer is no. Learn from your mistakes, correct it for the next patient or for the next exposure on the patient. So contrast, we kind of talked about that. Contrast just means difference. So we have to see a difference in tissue types, otherwise Doesn't do us any good, right? So think bone and soft tissue or bone and air. And contrast is the difference between those things. So what you're going to see in density in your questions on the test is overall darkening, overall blackening, overall, how dark the image is, that sort of thing. In contrast, you're going to be looking for things like gray, okay? So, or density differences between adjacent structures, okay? So even though the word density is in the question, it's density difference is contrast. Where density is how dark something is, density differences are the contrast between those somethings, okay? So generally it is going to say between adjacent structures. KVP, the reason that we've always used KVP to affect a control in contrast is because KVP controls your differential absorption. So if you make an exposure, I think I drew a step wedge up on the board earlier in the semester, but if you make an exposure where the only thing that you can penetrate is air, and you got air, soft tissue, and bone, then really the only thing that you're going to see is air and not air, right? So if you increase your KVP, you can penetrate air, soft tissue, and maybe not bone. So now you're going to see air, soft tissue, and not air, soft tissue, right? But if you increase your KVP even more, you're going to see air, soft tissue, and bone. Okay, so what you're doing there is affecting a change in differential absorption. Differential absorption just means absorption rate in different types of tissue. Okay, so KVP controls that. So as long as you use a KVP remotely in the right range for that tissue type, you're not going to see really any fundamental difference in contrast, because what controls your contrast is your lookup table, computer algorithm, right? So computer control with a lookup table. So, but the contrast things are going to come at you from a lot of different directions, okay? So grayscale, when we have what we're talking about with a long grayscale is we're seeing a lot of different types of tissues, all right? So, should have walked through this today. Probably. All right. So where we have high contrast, what we have is an image that's very black and white. Okay. So high contrast means a lot of difference between black and white. Okay. What that is a short grayscale. Okay. You might want to write these down because it's a lot. Okay. So high contrast, short grayscale. Okay, short grayscale just means that if you were to take all those levels of gray and spread them out on a graph, short would be just that, short. You wouldn't have a whole lot of different grays, right? Which is high contrast, which is a lot of contrast, right? Okay, so going the opposite direction with it, low contrast means that we've got a lot of grayscale. So that's a long grayscale. Low contrast means there's subtle differences between each one of those tissue types. Okay, so long grayscale means low contrast. Short or long scale contrast, low contrast. Okay, all right. So you might kind of stumble over that a little bit here and there, but just graphically, when we're talking about high contrast black and white, we've got basically 1, 2, 3 different shades of gray, as opposed to here we've got several more. So low contrast, many shades of gray. Long scale, also refer to that as high latitude. The reason we call it high latitude, and they'll still make a correlation between latitude and KVP, is for that reason we talked about before. So if we make an exposure on something that the only thing that we can penetrate is air, then the only thing we can see is air, right? So if we increase our KVP and we can see more tissue types, and we've got more latitude to make that exposure. High latitude, long grayscale means the same thing. Okay? So what is the correlation between technique and contrast? Not much, really. Not much. I'd say collimation is probably more important in the visual contrast in the image manipulation than what KVP or mass is. So very little correlation in a digitally reconstructed image unless you really over or underexpose a patient by quite a bit. So KVP is part of the reason that I keep saying that KVP, and will keep saying that KVP is probably going to play a bigger role in your technique formulation later on. I think you're sooner or later going to just be adjusting KVP much more so than what you will mass. KVP just doesn't have that effect on contrast anymore. Sometimes the practices have to catch up with the technology, and that's where we are right now. So something in technique manipulation you need to kind of hang on to is the difference between a 15% change in KVP and use of the 15% rule. So we've talked about 15% change in KVP. If we change our KVP, if we just increase our KVP, our patient dose goes up, our image exposure goes up drastically, right? So a 15% change in KVP gives us a doubling of the image receptor exposure, right? So with that doubling of image receptor exposure, patient dose is going to go up too, right? As opposed to the 15% rule. With the 15% rule, where we use that is to try to limit the patient dose by using a higher KVP. But if we use a higher KVP and we want to limit the patient dose, at least not make the patient dose go up, then we increase our KVP and we reduce our mass. So if we have, let's say we're doing a KUB on a pregnant patient, or even an IVP on a pregnant patient, which happens sometimes, or L-spine in the ER, you're probably going to run into that scenario at some point in your career if you're working diagnostic x-ray with a heavy ER load. Sooner or later, you're going to have to do an L-spine or a KUB on a patient in the ER in a trauma situation who's pregnant, okay? And, the thought is we've got to take care of mom before we can take care of baby, right? So they're always going to order the exam for the mom and then, consider the baby in the aftermath. So what you might do in that scenario, let's say you've got a good technique for a patient the size of that pregnant patient, but you want to limit the patient dose, what you could do is increase the KVP and reduce the mass. That's the application of the 15% rule. You increase KVP, you reduce mass by a factor of 2, right? So that's a 15% rule, as opposed to a 15% change in KVP just has to do with the increase in KVP to affect a change at the image receptor. It comes with a change in patient dose as well. Maybe not as dramatic as an image receptor, but it's still there. Okay? Any questions? No? All right, then we'll review on Friday and we'll have a test on Wednesday.